From question number 23. Membrane potential changes in isolated cardiac muscle cell are recorded along with ion movements across the cell membrane. See graph below. So we have two graphs, membrane potential and ion conductivity. Which of the following ion sequences corresponds to regions 1 to 3 on the graph respectively? Option A, potassium, sodium, calcium. Option B, sodium, calcium, potassium. Option C, calcium, sodium, chloride. Option D, calcium, sodium, potassium. Option E, sodium, potassium, and calcium. Pause it and give the answer. So the correct answer for this question is option B. Why this is option B? Because this one is because of sodium entry, right? Then this plateau is because of calcium, and this hyperpolarization or deep repolarization, this is basically repolarization, this is because of potassium, right? Okay, so this is not corresponding to option A, C, D, and E because they are not matching with this. Okay, so this is the phase of ventricular muscle action potential, right? So phase 0, then 1, then 2, then 3, and then 4, right? Okay, so this phase 0 is because of sodium entry. Okay, so uh, in this case we have phase 4, right, which is resting potential, which is during diastole, largely by membrane permeability to potassium ions. This is because of potassium ions, right? Resting potential of cardiac myocytes, that is approximately minus 90 millivolt, while skeletal muscle cells, that is approximately minus 75 millivolt. The highly negative resting potential of cardiac myocytes reduces the risk of arrhythmias. Larger stimulus is needed to excite the cells. Okay, so then we have phase 0, right? That is because of rapid depolarization is in skeletal muscles. Voltage gated sodium channels open, sodium ion rushes into the cell, just like I was saying. So phase 0 is because of sodium entry. Then we have phase 1, which is considered as initial rapid repolarization, which is because of closure of sodium channel, rapid closure of sodium channel. Then we have phase 2, that is plateau phase, which is the distinctive feature of the cardiac action potential not seen in other tissues. So they're talking about this phase 2, right? Okay, so which is because of opening of L-type dihydropyridine sensitive calcium channels and the closure of some potassium channels. Consequently, the membrane becomes highly permeable to calcium ions and minimally permeable to potassium ions. Okay, then we have phase 3, that is late rapid repolarization, right? This is because of potassium ions. So the closure of calcium channels and the opening of potassium channels, efflux of potassium from the cell restores the membrane resting potential. Now sodium ions influx corresponding to the red curve on the ion conductivity graph. So they're talking about this red curve. Okay, we talked about this. Then they are saying calcium ion influx corresponding to the blue curve on the ion conductivity graph. So that will also show positive uh, deflection. Okay, right. Then we have like decreased potassium permeability during the action potential upstroke corresponding to the green curve on the ion conductivity graph. Okay, so they're talking about the red one, sorry, the green one. Okay, good. So cardiac myocyte action potential, rapid depolarization, that is phase 0, initial rapid repolarization, that is phase 1, which is because of uh, uh, closing of the sodium channel. Then plateau phase, then we have late rapid repolarization because of potassium, that is phase 3. Okay, then we have phase 4, that is resting potential. So action potential is associated with increased membrane permeability to sodium and calcium, and decreased permeability to potassium. So the next question is, a 64-year-old man loses consciousness near the entrance to an emergency room. Okay, a physician rushes to the patient and palpates a strong pulse along the inner side of the left sternocleidomastoid muscle. The vessel palpated by the doctor is a derivative of which of the following aortic arches? Options: first, second, third, fourth, and sixth. Pause it and give the answer. So the correct answer for this question is option C. Let us see to the explanation why. If we if we look to the pharyngeal and aortic arches, then there are some cranial nerves that are associated, and there are key aortic arches derivatives. So pharyngeal arch, pharyngeal and aortic arch. First, trigeminal nerve, cranial nerve 5, and maxillary artery portion. Second, facial nerve, cranial nerve 7, stapedial artery, but that would finally regresses. The third, glossopharyngeal, cranial nerve 9. So common carotid artery, proximal internal carotid artery. Then fourth, superior laryngeal branch of vagus nerve, cranial nerve 10, true aortic arch and subclavian arteries. Fifth, uh, will be obliterated and obliterated. Okay, the sixth one, that is recurrent laryngeal branch of cranial nerve 10, right? That would lead to pulmonary arteries and ductus arteriosus. Okay, during embryonic development, head, neck, and upper thorax region develop from the set of arches known as pharyngeal arches. Each arch is associated with a cranial nerve and aortic arch derivative. The vessel palpated in this patient is common carotid artery, which, okay, a third aortic arch would give rise to that third pharyngeal arch. Okay, the third pharyngeal arch also give rise to glossopharyngeal nerve, that is cranial nerve 9, parts of the hyoid bone, and the stylopharyngeus muscle. Okay, first pharyngeal arch, trigeminal nerve, cranial nerve 5, tensor, tympani, muscles of mastication, maxilla, inner ear bones, that is incus malleus and stapes. Second, pharyngeal arch, facial nerve, muscles of facial expression, stapedial artery, second aortic arch. Okay, then we have the fourth pharyngeal arch, superior laryngeal branch of the vagus nerve, that is cranial nerve 10, many of the muscles of the pharynx and soft palate. Few of the laryngeal muscles associated with fourth aortic arch gives rise to part of the true aortic arch and subclavian arteries. Sixth pharyngeal arch associated with the recurrent laryngeal branch of cranial nerve 10. Most of the muscles of the larynx associated aortic arch gives pulmonary arteries and ductus arteriosus. Common carotid artery, proximal portion of the internal carotid artery, form from the third aortic arch. Third aortic arch is associated with the third pharyngeal arch, give rise to glossopharyngeal nerve, part of the hyoid bone, and stylopharyngeus muscle. Okay, so the first one is first arch, that is trigeminal nerve, cranial nerve 5. Second, that is facial nerve with red one, that is cranial nerve 7. Third arch, that is glossopharyngeal nerve, and fourth and sixth, that would be related to vagus nerve. So the next question, a 16-year-old previously healthy boy brought to the office due to palpitations. He was watching a documentary at a movie theater when his heart suddenly began to race and he became light-headed. The patient says that he felt rapid heartbeats in the past and thought that they were uh, due to stress from school examinations, but he's never had associated lightheadedness before. He has no chest pain or dyspnea. Physical examination is within normal limits. The resting ECG is shown in the exhibit. Which of the following is most likely present in this patient? Option A, accessory bypass tract connecting the atria and ventricles. Option B, cardiac conduction system degeneration below the level of atrioventricular node. Option C, ectopic atrial foci that serves as the dominant pacemaker.
Option D, impaired generation of impulses in the sinoatrial node. Option E, prolonged ventricular action potential due to myocyte ion channel abnormality. So pause it and give the answer. So the correct answer for this question is option A. Why? Because this is associated with the Wolff-Parkinson-White syndrome. That would give rise to sign and symptom of palpitations and lightheadedness, and that is associated with AVRT. Right? We will talk about that. Why not option B? Cardiac conduction system generation degeneration below the level of AV node. That would result in the conduction block. That would lead to symptomatic bradycardia. Why not option C? Ectopic atrial foci that serves as the dominant fist maker. Because of that, the P waves would be of variable morphology. They would show different morphologies, right? Like normally, let's say, if this is, let's say, on ECG, right? So some would give like a very high peak, right? Other things would be normal, while some would give very small peak, right? So just like that, you know, there will be variation in the P wave morphology. Okay, then why not option D, impaired generation of impulses in the sinoatrial node? That would result in sick sinus syndrome. Impaired generation of impulses in the sinus SA node, okay, sinoatrial node. So that would result in sick sinus syndrome. What will happen? There will be delayed P waves, or there would be absent P waves, right? Okay, why not option E, prolonged ventricular action potential due to myocyte ion channel abnormality? That would lead to long QT interval, and that would lead to torsades de pointes, right? Okay, so let's say this is a normal sinus rhythm, right? Okay, we have like this one over here, P wave, then we have QRS complex, then ST segment, then we have this T wave, right? Okay. Okay, so in Wolf Parkinson White syndrome, what happened is there are accessory pathways that would lead to re-entrant circuit. This is important, right? So ventricular pre-excitation would be there, like accessory pathway would result in ventricular pre-excitation impulse, right? There will be in Wolf Parkinson White syndrome, there will be delta waves, right? Okay, and there would be re-entrant tachycardia. Okay, so the pathophysiology is ventricular pre-excitation via accessory pathway uh, that bypasses the AV node. What will happen? There will be wide QRS complex, right? The QRS complex would be increased. There will be short PR interval because the P there is delta wave, right? So slurred upstroke of QRS complex that would result in that would result in delta wave, right? Okay, just like in this case in V5 we could see they have mentioned, like normally this is just like let me draw this. This is a straight line, right? I made it a little bit wrong. Okay, let me, okay, just like that. So this is, normally it should go up inclined, but here they are made just like that, a curve type. So that would become a delta wave, right? Okay, so so Wolff Parkinson White syndrome would show following triad: short PR interval, delta wave, QRS winding. So short PR interval generally less than 120 millisecond. Slurred and broad upstroke of the QRS complex delta wave. QRS widening often with ST segment or T wave changes. Then we have accessory pathway through bundle of Kent. There would be ventricular pre-excitation that would lead to paroxysmal tachyarrhythmias, episodes of palpitations and lightheadedness that are considered to have Wolff Parkinson White syndrome. So that would lead to consider to have, okay, Wolff Parkinson White syndrome. Atrioventricular reentrant tachycardia, that is atrioventricular AV, reentrant, that is represented by R, and tachycardia, that is for T. Okay, so form of paroxysmal supraventricular tachycardia, most common arrhythmia seen with Wolff Parkinson White syndrome. So why not option B? We talked about this degeneration below the level of AV node, like his Purkinje system. There would be conduction system, conduction block, and symptomatic bradycardia. Why not option C? Patient with wandering atrial pacemaker or ectapic atrial rhythm, so P waves of varying morphology. Why not option D? Impaired generation of impulses in the SA node that would lead to sick sinus syndrome, elderly patients. That would occur in elderly patients. Okay, so delayed P wave or absence of a P wave. QRS complex formed by junctional escape beat. So we can say AV reentrant tachycardia. So this is the pathophysiology for atrioventricular reentrant tachycardia. Accessory pathway connecting atria and ventricles creates a macro entrant circuit, usually trached by uh, premature atrial contraction or premature ventricular contraction, characteristic arrhythmia of full Parkinson-White syndrome. So there would be a rate of 140 to 250 beats per minute, regular RR interval, retrograde P waves, um, usually narrow QRS complexes. Now this is opposite of that of full Parkinson-White syndrome, right, where the QRS complex was wide. Okay, so why not option E, congenital long QT syndrome, mutation in the genes encoding cardiac sodium or potassium channels, prolonged repolarization interval. So QT uh, interval would be greater than 450 millisecond. Ventricular tach that would lead to that would lead to ventricular tach. For example, torsade de Pointes. So Wolff Parkinson White syndrome, um, uh, shortened PR interval, slurred initial upstroke, QRS complex, delta wave, widening of the QRS complex, accessory pathway, bypass the AV node, ventricular pre-excitation, paroxysmal tachyarrhythmias, uh, atrioventricular reentrant tachycardia, re-entry of electrical impulses. So that would lead to Wolff Parkinson White syndrome. Remember this thing, we have given grading to these different uh, markers, these different colors. The orange one has grade 4, right? So this is very important, you shouldn't miss this. Then we have this green one, this is grade 3, right? Then we have this little bit blue one, that is grade 2, right? And then yellow, that is grade 1, right? So this is important, so you shouldn't miss the one with orange color. And then the second important one is the green one, then the third one is uh, the one with blue color, and then the fourth one is not that much important, so keep that in mind. Thank you.